So in order to talk about internal derangement in the knee, probably it's best to show a normal knee in a adolescent child and then to show some examples of some of the typical diseases that make pediatric musculoskeletal imaging different from adult MSK imaging. So first, let's start with the normal knee, and this is an order that you don't necessarily have to follow as long as you do cover all of these essential structures. So here we are in the midline. If we look at our corresponding coronal fat suppressed proton density image, you can see that we're in the mid aspect of the knee. Here is the axial, which shows you corresponding pictures of portions of the menisci, and then here the sagittal proton density without fat suppression, as you see with the bright fat noted, and then the skin. So here, let's just move right out into the medial meniscus. Medial meniscus, as you can see, when you compare our other planes, is very dark and uniformly dark in signal intensity. In fact, the meniscal signal intensity is graded on a scale of 1 to 3. Grade 1 is a uniformly dark signal, and that's the normal structure and normal expected appearance in pediatrics. But remember also that a grade 2 can also be normal, and that is where there's some spotty increased signal intensity in the meniscus. It's typically along the posterior horn, in the lateral more than the medial, and that actually corresponds to increased vascularity in the meniscus, which should not be interpreted as a tear if there is no increased signal intensity extending to the articular surface on either side. We go from medial to lateral and see that the medial meniscus just gradually fades out into an anterior and a posterior horn with a body in the middle. We come to the intercondylar notch at the site of the root of the meniscus, and we must interrogate that on all images. We come out into the lateral meniscus, and we see again that uniform dark signal intensity with two parts of the bow tie but absence of the body. Keep moving out laterally and you see portions of the body, and then here is the true bow tie. When talking about the bow tie appearance of the lateral meniscus, this really is important to recognize in patients in order to understand what is normal and what's abnormal, and to differentiate a normal meniscus from a discoid meniscus. This all really depends on your image slice thickness and your interslice gap, but also the age of the patient, because of course younger children will have thinner menisci than older children. But suffice it to say, there are certain standards that say that you should see no more than 3 bow ties on a 3mm image going from lateral to medial, and this is the case here, essentially ruling out a discoid meniscus. Tears can be present in all sorts of shapes and forms, and we'll look for horizontal tears, we'll look for radial tears, we'll look for vertical tears, and there are specialized tears that are more common in pediatrics, especially in the face of a discoid meniscus, known as the bucket handle tear, where there is a displaced fragment. Now we'll talk about the cruciate ligaments, and there are two. One is anterior and one is posterior. We'll focus mostly on the anterior cruciate ligament and its normal appearance. We know that this is a very, very common injury, probably only second to the meniscal injury in children, and often is paired with meniscal injuries in high-level athletes, girls more than boys. So what are we going to look for the ACL? First of all, let's look at the normal anatomy. This is a normal case, and we are at midline here. Look at the comparison axial and coronal. And we can see here that the ACL is going to be this structure here that's sitting and flanking this posterior line along the posterior femur. And we can see that it's got dark signal intensity, it's got some intermediate signal intensity along the posterior fibers, and it courses from the anterior tibial spine up into the posterior aspect of the femur in the intercondylar notch. What we're going to look for on all sequences is this typical dark fiber band, and that's most important, the signal intensity. But also what's important is to look for how taut it is and that it's not sagging, and to look for discontinuity in the case of a complete tear. In the younger children, we'll also look for the tibial spine and look for evidence of a fracture of the tibial spine, because in those before the growth plates are mature, you're going to have the highest risk area, or the weakest area of the knee is where the ACL originates, which is at the tibia, and that's the tibial spine. So a tibial spine fracture may be what happens with an ACL tear, and the ligament itself might actually be intact. So the ACL here, and on its corresponding coronal image is here, showing an intermediate appearance on the proton density and a slightly more, a darker appearance on the T1. Corresponding image here is the axial, and you can see that it's got an intermediate signal intensity on this axial proton density. Looking now at the PCL, the posterior cruciate ligament is this structure here that takes sort of a curvilinear bend and is very, very uniformly dark. We can see it nicely on the proton density images, both on the axial and the coronal. As we can see here, it's a very dark structure on the coronal. As we move along from its course from the femur to the tibia, we can see it's uniformly dark. You can see this on a corresponding axial image. It's this structure here. And the PCL, again, just like the ACL, we look for increased signal intensity in the fibers, or we look for a curvilinear or a bowing course, or complete discontinuity as signs of tears. Okay, the collateral ligaments, for simplicity, these are best seen actually on the coronal and axial images, but we'll just show the proton and the T1 for best illustration. So the medial collateral ligament here, lateral collateral ligament here, these are structures that should be dark, 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 both on the T1 and on the fluid-sensitive sequences. Here we see medial collateral ligament to start is a very thin band, and it should be dark. It should not have any areas of bright signal intensity. It should not be thickened at all. And the medial collateral ligament tears, therefore, are graded on a scale of 1 to 3. Grade 1 tears are where the ligament actually looks normal in its signal intensity, but it has a little bit of high signal intensity on the fluid-sensitive sequence, both outside and inside, or superficially and deep to the medial collateral ligament. And that's known as a microscopic tear, or a grade 1. Going up in severity, a grade 2 will have a thickened ligament, and it may have some areas of higher signal intensity. and again surrounded by edema. A full disruption of the medial collateral ligament is a grade 3, and it will literally look retracted, thickened, high in signal intensity, and be surrounded by variable amounts of edema, because usually these kids with severe valgus strain are going to have a lot of surrounding edema because of associated tears of other soft tissue structures. Let's look at the lateral collateral ligament now. First, anatomy. This is a complex of 3 different insertions. We have the fibular collateral ligament, which is seen here. Fibular collateral ligament. We have the biceps femoris tendon, and we have the iliotibial band. So all 3 of those things are inserting into the fibula and forming this sort of compound tripartite ligament complex. Just deep to these is the groove for the popliteus tendon. This is another structure we need to look at because this not infrequently shows evidence of partial or full thickness tear. So medial collateral ligament, thin dark band, lateral collateral ligament, 3 dark bands, and again, grade 1 to grade 3 applies to the lateral collateral ligament as it does to the medial collateral ligament. Finally, looking at the soft tissues, including the joint spaces, is key. And one needs to both identify fluid in the joint space and to characterize it as either clear fluid, blood, fat with blood, the latter indicative of a fracture, or nodularity within the fluid, suggesting that there's some other thing in the fluid other than just synovial fluid, such as synovial hypertrophy, or perhaps nodularity related to tumor or synovial osteochondromatosis or pigmented villonodular synovitis. So to characterize whether there's fluid or not, and then to characterize the actual signal intensity and homogeneity of the fluid is important. Let's look at this sagittal, almost midline view of the knee. This is the proton with fat sat again, and here we have it again on an axial view, and then for comparison, the sagittal proton without fat suppression or saturation. And we see here on this fluid sensitive sequence that even a very tiny amount of fluid is going to be seen as bright on this sequence. Where we look for fluid most often is there's a little suprapatellar bursa that sits underneath the quadriceps tendon and is bordered by a little pad of fat, and it's this area here that will collect fluid and actually is most sensitive to physical examination and also accessible for joint tap if one needs to get a sample of the fluid. Note also that fluid will collect sometimes behind the cruciate ligaments and also anteriorly, and one should never accept any fluid collecting down here, which is the inferior anterior corner of the knee, known as Hoffa's fat. That always indicates there's something wrong in this lower portion of the knee, which we will address in following segments. So in this case, we have a physiologic amount of fluid. We see it extending into the suprapatellar bursa. This is all a continuous space, and we would report it as such. The axial image again shows this tiny amount of fluid that as we come down to the patellofemoral joint space is just small, homogeneous, and not anything to worry about. The soft tissues finally surrounding the knee, one wants to comment on edema that exists in the knee, in the skin of the knee, the subcutaneous fat, and also within the deeper structures. You often get a very good look on the axial image for the same thing, because you'll often see lots of areas of transspatial edema in significant knee injury. I'll address one other feature on this study today, and that is the avulsive cortical irregularity. And that is a small bony defect that happens at the posterior aspect of the knee along the medial joint space. And it's this little structure here. And what it is related to is it's related somehow to the insertion of the medial head of the gastrocnemius muscle. but it's an excavation of the bone with normal overlying cortex and normal inserting musculature without any surrounding edema. So an avulsive cortical irregularity, or also known as a desmoid, is a normal variant.